because you are still growing, or you may break your limb, and therefore you need new vessels to form, you will have at one point in time, both prenatal and postnatal, the angiogenic sprouting from existing vessels into a new avascular tissue. Okay, all of these vasculogenesis and angiogenesis is determined by growth factors, and there are different growth factor families, and they each have a certain role. The first family that we will have to discuss is the vascular endothelial growth factor family, i.e. it's not only a single growth factor, but there are multiple growth factors. And they are not only acting on one receptor, but they're acting on multiple receptors. So what I'm now here presenting is already very primitive type of describing something that is way more complex. We have an angiopoietin family, we have an afferent family, and then we have growth factors that are not acting on the endothelial cells, that's TGF-beta and platelet-derived growth factor dependent ones, and all of these growth factors obviously have to work together in a coordinated manner to be able to form your mature blood vessels. VEGF is the first one, and VEGF is the most critical driver of vascular formation. In fact, VEGF initiates the formation of immature cells by either vasculogenesis or angiogenic sprouting. Immature cells means, and this will be of importance later, that they are not yet associated with the pericytes, with the smooth muscle cells, and that they are therefore having certain aspects that are different from mature vessels. Immature cells, immature vessels will be leaky and will therefore demonstrate contrast enhancement. This will be of importance when we are discussing certain tumors later. VEGF itself is regulated. VEGF is regulated by the oxygen tension within your tissues. So if the oxygen tension is low, then the tissue will derive the hypoxia-inducible factor, and HIF, the hypoxia-inducible factor, will start to upregulate VEGF. So wherever you have low oxygen tension due to an increase of HIF, you will have an increase in the vascular endothelial growth factor. If you give only VEGF to an animal model without the other angiopoietins or afferents, without the other growth factors, you will have only leaky, immature, and unstable blood vessels. Similarly, if you have an animal model where you have no receptor for VEGF, so VEGF receptor number 2, then you have no vasculature, very few endothelial cells, and this is obviously a lethal mutation. An example of VEGF regulation is the retinal vascularization. And here we have the first clinical application, not so much for you as interventionists, but for those of you who work, let's say, in an ICU or a PICU for immature babies. When they are born, they are being put into an incubator. In the incubator, there will be a very high oxygen tension. And a very high oxygen tension will now mean that their retina will not need any blood vessels that are sprouting into the retina because they are getting enough oxygen from the air. And therefore, when they are now coming out of the incubator and coming into a non-oxic territory, the retina will now be hypoxic. And when the retina is hypoxic, what will happen? HIF will be upregulated, VEGF will be upregulated, and now you'll have leaky blood vessels within the retina, which will lead to hemorrhages in the retina, and therefore babies that are being taken out of the incubator too early on have a high likelihood to become blind. This has been demonstrated not only in the clinical setting, but also in these mice models here that demonstrate very nice how the interplay of VEGF with your oxygen tension, how important this interplay is. Okay, what else do we need? We need the angiopoietin families, and here we have like two different angiopoietins, 1 and 2. They act on the so-called Ti receptor. If you have mice that do not have angiopoietin 1, they develop a normal primary vasculature because this is derived by VEGF. But there's a failure now to associate these primary vessels with their support cells, the smooth muscle cells and the pericytes, and this will lead to, like, again, leaky blood vessels, less mature blood vessels, and a missing remodeling of the primary vasculature. On the other hand, if you have too much angiopoietin, you will have a hypervascularization with an increase in the vessel size, but not the vessel number, because remember, the vessel number is determined by VEGF. And these vessels, where you have an overexpression of angiopoietin 1, will be resistant to leakage. Now, up to now, only spoke about angiopoietin 1, that is kind of can be seen as a stabilizing growth factor. But remember that during remodeling, we not only have the maturation, but we also need to have the possibility of pruning of vessels that are no longer needed. And therefore, you need not only a stabilizer, but you also need a destabilizer. That's angiopoietin 2. And what do I mean with this? Angiopoietin 2 allows the endothelial cells to revert to a more plastic state that will either lead to regression of the vessels in the absence of VEGF or to the formation of new vessels in the presence of VEGF. And this is of importance when you're thinking about your growing body. Right now, let's say, when you're 12 years old and you have a growth spurt, your stable vessels have to become unstable to be able to grow into avascular tissue. Therefore, you need a destabilizing agent. Now, so angiopoietins are therefore important for pruning and initiation of angiogenic sprouting. Or, in general, angiopoietins are important for the maturation, remodeling, and stabilization, and maintaining the stability of mature vasculature. So if you recapitulate, VEGF makes blood vessels, angiopoietin stabilizes or destabilizes blood vessel to make a mature, constantly remodeling vasculature. And now we need a third agent. And the third agent, or the third group of like growth factors, are the efferents. And the efferents give an identity to your blood vessel, i.e., will this vessel become a lymphatic vessel, will this vessel become a vein, or will this vessel become an artery? So there are certain efferents that will make a vessel become an artery, that's 2, and there are certain receptors that will make a blood vessel become a vein, that's efferent B4. And of interest is that these efferents also regulate the interaction between the smooth muscle cells and the endothelial cells, and its receptor participates in the guidance of axons and CNS development. Now, for those of you who are diagnostic neuroradiologists, you presumably know that there is an association with developmental venous anomalies and cortical dysplasias, right? That's the cortical dysplasia type 4. Or that there's an association with polymicrogyria and brain AVMs. And this is related to the fact that there's a disorder of the radial glial guidance that is mediated by your efferent B4, as well as a disorder of your venous identity that is regulated by B4. Therefore, you will never be able to see your blood vessels in separation from the surrounding tissues, but they are interacting and they are closely intermingled with each other because they are using and reusing the same type of receptors and growth factors. Okay, we talked about the definitions and the growth factors and their roles, and just to recapitulate, VEGF makes blood vessels, angiopoietin stabilizes blood vessels, and the efferents give an identity to your blood vessel. Now let's go and make a little bit of a deeper dive into vasculogenesis. In a primary avascular tissue, endothelial cells will differentiate and proliferate and form this primary vasculature right here. And where does this happen? It happens actually in the mesoderm that will make the heart and the blood vessels. And you can see here the ectoderm, you can see the endoderm down here, and in the middle of it there's the mesoderm. The ectoderm is of importance for the CNS and the peripheral nervous system, whereas the mesoderm will be of importance for your internal organs. Now what happens if this is your ectoderm, this is your endoderm, this is your mesoderm? Certain cells will segregate from the mesoderm and migrate towards the endoderm. While they are migrating towards the endoderm, they will form vascular cords, and these vascular cords will coalesce to form endothelial cells and the primary vascular network. Of interest, the same cells, the same progenitor vascular cord cells that will make the blood vessels will also make your erythrocytes, your corpuscular blood vessels. And this vasculogenic mesoderm is promoted by endoderm. This is why the migration is towards the endoderm. It's promoted obviously by VEGF and is inhibited by the ectoderm. You can see here the neural crest, soon to be neural tube. You can see the progenitor cells that are migrating here towards the endoderm to form the primitive vascular cords and endothelial cells. Now this, of course, as we discussed before, is regulated by growth factors. And it's regulated by your oxygen tension. So if you have an area of low oxygen tension, HIF will be activated, HIF will activate VEGF, and this will lead to like endothelial cells to sprout into the area that was previously undersupplied by oxygen. Next, we have to form and give the arteries and veins their identity, and this is mediated by the ephrins and by the notch receptors, and the bilateral dorsal aorta. They become molecularly distinct from the veins before the blood circulation, and therefore before angiogenesis. So your identity of the blood vessels is determined very early on in your prenatal life. An important factor or important point to make is where the blood vessel cells are coming from. As I said, the mesoderm makes the endothelial cells, and in the body it's also that the pericyte, smooth muscle connective cells are all being derived from mesoderm. But our brain is somewhat different. Our central nervous system has a different origin of your blood vessels, and this will be of importance when we're talking about how, let's say, different stents work in the periphery versus in the brain. Because if you think about the peripheral blood vessel, everything is derived from the mesoderm. In the head and face, the pericytes, smooth muscle, and connective cells are actually derived from the neural crest, i.e. from the ectoderm. So for your blood vessels in your head and face, you will need a coalescence of mesodermal cells as well as ectodermal cells, which will explain to you why you will have certain diseases that will be present in like an ectodermal distribution. These will be the cerebrofacial arteriovenous metameric syndromes. It also explains to you why it is very difficult to make a one-to-one translation of, let's say, how a peripheral stent, an iliac stent, will work in the central nervous system, or how a cardiac stent or how sirolimus coated stent will have the same effect in the brain, because the vessels are having a different origin. So this is, I think, an important factor to keep in mind. Okay, now let's go from the vasculogenesis towards first the embryonic angiogenesis. Angiogenesis means that the primary vasculature that is made by vasculogenesis has to be remodeled. Certain vessels are no longer needed, certain vessels need to become larger. And this angiogenic remodeling is obviously mediated by angiopoietin 1 and angiopoietin 2 for the remodeling. So you need to have some pruning and some vessel enlargement. And this is best exemplified by how your pharyngeal arches during embryogenic development change over time to become your carotid artery, your vertebral arteries, your external carotid artery, and your internal carotid artery. Here we have the arteries of the pharyngeal arches, and you will see that over time these primitive vasculatures change, and you will have a more mature type of vasculature. But you have to also remember that things may go wrong, and this can explain arterial variations. Where you have, for example, a lusoric subclavian artery, or where you have other variations that I think Insut will discuss with you in greater detail. Let's move now towards the postnatal angiogenesis. The postnatal angiogenesis is occurring throughout our lifetime. Even now, as we are sitting, our vessels have to change. In fact, it is believed that our vessels are being completely remodeled, completely exchanged every 7 years. So the vessels that you have now, your endothelial cells that you have now, will be different from those that you will have 7 years from now, which will become of importance when we are talking about, let's say, the effect of radiosurgery on brain AVMs, and whether there may be actually a risk for recurrence of a brain AVM if the problem is within the cell and if the cell is not taken out. But this will become discussed later. So, angiogenesis, the postnatal angiogenesis, means that your remodeled vasculature has to go through a certain destabilization process. The destabilization process, again, angiopoietin 2, makes the vessel unstable. And then this vessel has two potential fates. In the presence of VEGF, it will lead to angiogenic sprouting, i.e. new vessels will form and go into avascular tissue. In the absence of like a lack of oxygen, i.e. if there's enough oxygen, that means that enough vessels are somewhere else, then this vessel here is no longer needed and will regress. And this postnatal angiogenesis starts off with a dissolution of the outer neural elements, activation of the endothelial cells, which will be of importance when we are talking about the KRAS mutations that can cause a brain AVM to develop. We will have a directional sprouting towards where there is no oxygen, because this is where VEGF is, and it will kind of tell the vessels to move there. Then these immature vessels have to be recovered with parasites, i.e. they have to become mature again, stabilized, and then there's a reconstitution of the normal vessel wall. The postnatal angiogenesis will reuse the same growth factors and their receptors that were also used during vasculogenesis and prenatal angiogenesis, i.e. VEGF, angiopoietin, and the time receptors as well as VEGFR. Some peculiarities of endothelial cells are demonstrated here. Normally, these endothelial cells rarely divide. They only divide between like once in 3 to 14 years on average every 7 years, which is why I said that your endothelial cells will renew every 7 years. But they can be induced to replicate to once in 5 days. And this makes perfect sense, because let's say you cut yourself and now you need a new blood vessel to form here. You can't wait for 3 years or 7 years for this new blood vessel to form, so you have to get it induced to replicate very fast. And this is, of course, again, hypoxemia and inducible factor that will lead to an increase in VEGF. And they can be induced to replicate very fast if you have something that is growing very fast, for example, a GBM or any other type of malignancy that is now starting to grow. Because when this tumor is growing, there's first an avascular tumor growth. which means that there's still enough oxygen tension surrounding the capillary bed for the tumor to have enough oxygen. But at one point in time, there's not enough oxygen. And in this moment, there will be a hypoxic tumor, and HIF will be activated, VEGF will be activated, and you will have an angiogenic sprouting into the tumor. Angiogenic sprouting is mediated by VEGF. VEGF makes leaky vessels, and this is why a GBM would demonstrate enhancement. Now, how do we treat a GBM? Of course, we can do surgery, radiation, but we can also give Avastin. What is Avastin? Avastin is a VEGF inhibitor. And if you now give a VEGF inhibitor into the tumor, the idea is that there is no longer any growth of blood vessels into the tumor, and the tumor will die from the inside. But those of you who are neurosurgeons or neuroradiologists, you know the terms of pseudoprogression. Pseudoprogression means that the tumor, it's pseudoregression, means that the tumor looks as if it no longer enhances and is therefore dead, but in truth it's still growing because the flare hyperintensity is still growing. And now you can understand why this is the case. Because what is Avastin doing? Avastin is inhibiting VEGF, i.e. it will make less leaky cells, and therefore there will be less leakage, and therefore there will be less contrast enhancement within the tumor, although the tumor may still get its oxygen from other places. So understanding VEGF tumor biology will help you to understand the imaging characteristics of a GBM under the treatment with anti-VEGF drugs. Okay, we talked about the definitions, the growth factor, vasculogenesis, the embryonic and the postnatal angiogenesis. Now we will have to talk about the concept of the angiogenic switch. And this means that we'll have, during angiogenesis, two different processes. The first process is, let's call it the activation phase, where you have an increased permeability of the endothelium, the basement membrane degrades, and now you will have the formation of endothelial sprouts that move towards where VEGF is present. And due to cell division, we will have luminal formation. Okay? However, this has to stop at one point in time. And therefore, we'll need to balance the activation phase with the resolution phase. And the resolution phase means that there has to be a stop of the endothelial cell proliferation, that the basement membrane needs to be reconstructed, and that endothelial junctions need to be reformed. And this changing from the activation to the resolution phase is the so-called angiogenic switch. And this angiogenic switch is mediated by at least these two hormones, endocrine and ALK1. And if these are missing, you will have an imbalance of activation versus resolution phase. This will lead to structural abnormalities of vessels, and this can cause pathological shuts. And the disease in which we have either a mutation in the endocrine gene, or a mutation in the ALK1 gene, or mutation in the SMAP gene, is HHT, hereditary hemorrhagic telangiectasia, that is characterized by abnormal shunts in your body. We'll talk more about this later when we are going more into the applications of this disease. The other importance of this angiogenic switch, of the difference between the activation and the resolution phase, is in this area here where you have the formation of endothelial sprouts. This is where the KRAS pathway will become of interest. That is another different pathway from the HHT pathway that can explain AVMs. Because in the KRAS pathway, you will have an overactivation of the sprouting luminal formation, and therefore there are too many blood vessels moving into a tissue that have no connection and they have no use, and they will form a sporadic brain AVM. So understanding the angiogenic switch will help you understand how shunts, how arteriovenous malformations are actually formed in the body. So in HHT, you have HHT1, you have HHT2, there's now HHT3 with the SMUG gene, and HHT4 where we have not yet found the gene. But all of these are genes that are able to mediate the angiogenic switch and are therefore, if defective, prone to making abnormal arteriovenous shunts. Okay, now comes the more interesting portion for those of you who are still awake. This is for the applications of what we've just learned. And we will go through a couple of them here, and some of this will come back during various other lectures, but we believe that redundancy, especially in this complex topic, is really of importance for you to understand this concept. So let's first talk about the so-called etiological classification of brain vascular malformations. When we are talking about etiological classification, you first have to understand what previous classifications were out there. There was, of course, the Russell and Rubinstein classification, who differentiated brain against carcinoma, capillarity, angiectasia, and venous angiomas. That was a good but oversimplified classification. And there's another classification that I believe is closer to our understanding of what a brain vascular malformation is. And that is the classification that Pierre Lagunière proposed, where he said the classification of vascular malformation needs to rely or rest on three different pillars. The first pillar is which structure is actually like being targeted, i.e., is it an artery, is it a vein, or is it a lymph vessel? When does the target when is the target hit? Is it very early or is it more later? And what is the nature of the triggering event that hit the target? And this will help us to now make a classification that is based on these three pillars or tiers. The first one is the target. As I have discussed with you, arteries and veins are not just simple pipes. They are molecularly distinct prior to angiogenesis and after vasculogenesis. So a blood vessel will know what it will be very early on. In fact, the angioblasts, they have not yet a specification. The primitive vasculogenic network, not yet neither. But in the moment before we are going towards angiogenesis, they will know whether they will become an artery, a vein, or lymphatic vessel, because the receptors that are being expressed here, an example for the lymphatic versus the venous vessel, will be completely different. There will be an upregulation of the VEGF receptor 3, then you will become or get a lymphatic vessel. In a downregulation of VEGFR3, this will become a vein. So this means that your vessels are molecularly distinct targets. Okay? Because if their receptors are different, then certain triggers can only hit the arteries, or can only hit the veins, or can only hit the capillaries. And therefore, you will have diseases that are determined on where they are being hit on the arterial, venous, lymphatic tree. You will have purely arterial diseases, aneurysms, dissections. You will have purely venous diseases, carcinomas. You will have something in between, arteriovenous diseases, i.e. where the capillary bed is being hit. These will be the shunts. Okay, then we'll have to discuss the second pillar. This is the timing. When does a certain trigger hit the arteries? Is it very early on or is it very late? Remember how your blood vessels in the brain and in the head and neck region form. They are coming both from the mesoderm and from the ectoderm. And your cells of the ectoderm migrate in a predetermined way towards their target organs, i.e. a cell that is like in the first segment of your embryo cannot go to a third segment in a different pharyngeal arch. It will always go to the same predetermined area. In fact, you can map those predetermined co-paths and see where they are going. So here you can see how certain cells only migrate into certain metameres. And while they are migrating into these metameres, they are seeding their daughter cells along the pathway. So let's have a cell that is migrating from here, and it's still normal. And now a trigger hits this cell, and now it's no longer normal. And now it starts to migrate. And while it's migrating, it will seed abnormal daughter cells along its pathway of migration. And therefore you will now have abnormal cells in this entire area of the migration pathways if the trigger hits very early on. As compared to if the trigger hits very late, you will have a way more focal impact. And therefore, you can now cross-tabulate. If you have the early head, large impact, late head, focal impact, you can cross-tabulate arterial diseases where the trigger hit very late, that are more focal, arterial segmental diseases, arterial metameric diseases. You can look at arteriovenous or capillary levels and the venous level. And we can now add a third dimension to it. The third dimension is the nature of the trigger. And here we have proposed that there's a balance between genetics and environmental roles. So for example, we have the monogenetical diseases, HHT. Now we know that AVMs are having a very more significant role of genetics as compared to purely environmental triggered diseases, like in the worst case vascular trauma. And therefore we will be able to differentiate whether there is a more genetically predetermined lesion or whether there is a less genetically predetermined lesion. And this will allow us to add the third dimension here that will tell us whether we have an arterial focal disease, for example, aneurysm or dissection, or an arterial focal disease that is genetically determined, ehlers-danlos, polycystic kidney disease. Arteriovenous diseases, focal, arteriovenous fistulas or AVMs, or genetically determined, HHT. Cavernomas, familial cavernomas, segmental diseases, metameric diseases, genetically determined metameric diseases. And of importance, as in everything in medicine, this is not like fixed and rigid boxes, but this is a spectrum of diseases in the various forms. Okay, that's the first application that you can use or derive from this talk. The second one is trying to understand the congenital nature of vascular diseases and brain vascular malformations. If you look at these two patients, what do they have in common? This patient has an aneurysm with a subarachnoid, this patient has an AVM with a bleed. What these have in common is that we are seeing them at the clinical stage, where the lesion has become already symptomatic due to hemorrhage, epilepsy, mass effect, etc. But we as radiologists or neurologists and neurosurgeons, we know that prior to the clinical stage, there's a morphological stage. There you have the unruptured aneurysm, the unruptured AVM, where the lesion is visible, however not yet symptomatic. But what comes before? And when you have listened to this talk, you know that prior to the morphological stage, there is actually a biological stage, a genetical stage, and a pre-pathological stage. And this is an important concept to try to understand when we are talking about vascular malformations and how they form, and it will tie into the second hit theory of vascular malformation. And in order for you to understand what I'm meaning with this, let's take an example here. Let's say we have a cell here, and this cell has a chromosome, and everything is peachy. The cell is fine, and the chromosome is fine. But now we have a first or causative trigger. And this makes a cell with a defective chromosome. Now this cell with a defective chromosome has two fates. Either it dies, okay, so no damage done, or it will start to proliferate. And while it is proliferating, it will seed its daughter cells along its pathways, or it will be in the entire body. And then you will get towards a biological stage where you have an organ with a weakness, but not yet the disease. And then due to the second trigger, the revealing trigger, you will now enter the morphological stage where there's the organ with the disease that will then become at one point in time symptomatic. So let's give us an example, and let's go and move away from the vascular world for a brief example, and take neurofibromatosis. You have due to the first causative trigger, a mutation in the neurofibromin gene. This mutation in the neurofibromin gene is not lethal, and you will now have this mutation in your entire body. But when you are born with neurofibromatosis, you not yet have a vestibular schwannoma, which only have the propensity to develop a vestibular schwannoma. And due to a secondary revealing trigger, you now have your brain with a neurofibroma, with a schwannoma, with a meningioma. Okay? Or let's take now back the example of HHT. Let's say you have a mutation in the endocrine gene that was revealed through your primary trigger. You have the disease HHT with a propensity to develop AVMs, with a propensity to develop capillary telangiectasias, with a propensity to develop nosebleeds. But the baby, when it's born, is not necessarily having nosebleeds. They develop later on because due to a secondary or revealing trigger, you now have the asymptomatic AVM. And then to some changes within the brain AVM that we will discuss about later, you will have the symptomatic AVM, i.e. the ruptured AVM, and the AVM with epilepsy. So what I'm trying to tell you with this little excursus is, we are seeing patients here and here, and we are treating patients here and here, but we have to understand that we have the option at other, lower levels to already tackle these types of challenging diseases. So are therefore AVMs in HHT congenital? No. But they are inherited. This does not mean that they are present at birth, similar to vestibular schwannomas not being present at birth in neurofibromatosis. What about sporadic AVMs? This is work that we did back in Toronto with Ivan Radovanovic, where we looked at the sporadic AVMs and where we found that a certain mutation is being present in the large majority of patients with sporadic AVMs. And this mutation is of importance for cell migration, and this cell migration means that the cells, they are now migrating without the signal guidance from your HIF-VEGF, and therefore have no idea where to go to, and have no idea what to connect to, and will therefore form those brain arteriovenous malformations. And so, at one point in time, the causative trigger has made a mutation in the KRAS mutation in an endothelial cell. Let's say this endothelial cell here. But this leads to a dormant but transmittable defect. And now, every 7 years, your endothelial cells regrow. And during this regrowth process, during this remodeling process, this primary defect can become or can reveal itself. And then all of a sudden, you will have a de novo brain arteriovenous malformation due to unmasking of the primary defect. So therefore, AVMs are not congenital. Look at this example here. This is at time point 1. This is at time point 2. Clearly, this patient didn't have an AVM here, and clearly the patient has an AVM now here. And so genetics play certainly a role in this, but maybe also other factors. This patient happened to be a young female patient with liver cirrhosis, and we may believe that some form of either like genetics together with pro-inflammatory changes has made this AVM kind of a form de novo. Okay, now going to the third aspect of the applications, what we've learned, understanding diseases and their angiographic appearance. Let's first talk about von Hippel-Lindau disease. In von Hippel-Lindau disease, you have the loss of the von Hippel-Lindau suppressor protein. And what does it suppress? It happens to suppress HIF. Therefore, in patients who have von Hippel-Lindau disease, you have an accumulation of the previously suppressed products, i.e. HIF is skyrocketing, which means that what will now increase? VEGF. And if VEGF increases, we will have what? Accelerated growth and high vascularization of immature cells that demonstrate, therefore, significant enhancement. And guess what? This is a classical hemangioblastoma. And here you can see these immature cells that have no longer like the normal stroma surrounding it. They have no capsule, and they are just leaky blood vessels within the brain. Or we can explain the disease that was in the English literature called viral Mason syndrome, in the French literature, Bonnier-Chamblon disease, and that Pierre Lagenias coined cerebrofacial arteriovenous metameric syndromes, or CAMS. We will hear more about this later, but remember that in general, for the head and neck phase, you have to have the coalescence of mesodermal and ectodermal cells. The ectodermal cells go along their determined pathways, and they are transmitting their daughter cells along these migrating pathways. And the migration pathways happen to be for the prosencephalic migration pathways towards the midline structures, the hypothalamus and the nose. Towards, for the mesencephalic pathways, the diencephalon, the chiasm, the retina, and the maxilla. And for the rhombencephalic pathway, the cerebellum and posterior fossa structure, as well as the mandibular. Which means that if you have nose AVM, there's a high likelihood for this patient to also have a midline AVM, a corpus callosum AVM, which is one of the reasons why whenever we are seeing for the first time a patient with a brain AVM, we should always inject the external carotid arteries to look for the potential of these metameric syndromes. Here's another example of this CAMS2, where we have a vascular malformation involving the thalamus here and the maxilla here. Or here's an example of a rhombencephalic type where we have a mandibular AVM together with an AVM within the posterior fossa. Understanding what we've said can help you understand HHT, or hereditary hemorrhagic telangiectasia. Either endocrine or ALK1 are missing, and this can lead to pathological shunts. The group of Huasu at UCSF looked at this a little bit more in detail, because not every patient with HHT develops a brain AVM. So they devised a mouse model that was deficient of ALK1. And if there's only deficiency of ALK1, no AVMs formed. It was only in the presence of deficiency of ALK1 together with the presence of VEGF that an AVM formed. If ALK1 was present, even if VEGF was present, no AVM formed. So therefore, this group identified presumably the second hit. The first hit was that ALK1 is missing. The second hit was that somehow you need a situation where you have an increase in VEGF, and then the brain AVM forms. And this is, I think, a very interesting potential target in the future for our treatment. Like in Toronto, we did this endometrial knockout mouse. And for this, we were able to demonstrate that there are two different types of vascular malformations that were forming. The direct arterial venous fistulas and the nidus type AVMs. Have a look at this mouse model as compared to the real thing. This is a newborn baby with HHT. You can see the direct arterial venous fistula, similar to this one here. Or here, you have a microcatheter injection of a patient with HHT with this nidus type AVM right here. And we believe that these structural abnormalities can actually be explained by the endometrial knockout. And as I said, the UCSF group is now going one step further and is looking at, can we use now in patients with HHT VEGF inhibiting drugs to make AVMs even regress. And this is a model that has its problems for sure, but at least in this case here, avastin was injected into this structure and AVMs did regress. A couple of issues that I have with this model, because these structural shunts, they are already there, so I'm not completely sure how the avastin can actually make them regress, but at least it's an interesting area to work towards. And remember, this is the cascade in HHT. And this cascade actually means something else. It means that we may need to investigate children who are diagnosed with HHT in a serial fashion. Because if it's true that at any point in time a revealing trigger can trigger the organ with a weakness, that means that an AVM in patients with HHT may form de novo later on. And this was challenged. So we looked at our brain vascular malformation consortium database and looked at more than 300 patients and found 4 patients that had indeed a complete de novo formation of a brain AVM. And so here are a couple of examples. At age 10 years, this is a completely normal T2 weighted MRI. Especially look at this area here. I don't see any abnormal vessels here. And at age 16, there's clearly an abnormal vessel here. It was not there before. T1 weighted sequence is in the same. This is 6 years before. No abnormality here. Clear vascular malformation right there. Or this patient here at age 14, no abnormality in the left paramedian frontal lobe. At age 17, there's clearly an AVM right there. So brain vascular malformations can occur over time, which tells you if you have a patient with HHT in your clinic and the brain MRI is normal, it doesn't mean high and by. It means that in 6 or 7 years, you should see him or her again. The concept of angiogenesis also explains to you the way that certain AVMs look like. You see here a patient with a brain AVM, and clearly the AVM is here. And then you see often around the patient's brain AVM a cluster of abnormal vessels that are not shunting. And what are these? These are neo-angiogenic vessels that are sprouting into this brain region because the brain AVM is sucking away all of the blood and therefore all of the oxygen into the AVM, away from the normal brain, therefore causing local hypoxemia in the brain region around the AVM. So this is called perinidal angiogenesis, and it's of importance to realize this because these vessels are VEGF induced. And those of you who are neurosurgeons know that surrounding a brain AVM, there are often the so-called angry red vessels, i.e. those vessels that are, like when you just touch them or look at them, they are starting to rupture. They are very difficult to control because they are not normal vessels. They have no normal pericytes, as smooth muscle says, because they are VEGF induced. And they would go away if you hit the cause of the brain AVM, if you take the AVM proper to prevent the perineal angiogenesis. Another example for this perineal angiogenesis is seen here. Large AVM, and you see that the normal distal MCA territory is no longer filled because everything is sucked into the AVM. So these are not AVM vessels, right? These are just collaterals that the body recruited because of the perineal hypoxemia that made the vessel crave for oxygen, made the brain crave for oxygen distant from it. Okay, let's move on to understanding complications. We had here a patient with a brain AVM. You see clearly the AVM here. Planted our microcatheter there, injected the liquid embolic agent, and you see that the liquid embolic agent just stayed within the feeding artery, did not go into the nidus, did not go into the vein. What will happen in this patient? If only the vessel is ligated, have you cured the patient? No. Because what you have done now is the AVM, the abnormal cells, are still there. And the brain surrounding it is hypoxemic, which means HIF, VEGF, new vessels are forming, sprouting, and of course will interconnect with the still present AVM. And so, you see now, it's no longer filled by the ICA, but now by SCA branches. So a ligation embolization in brain AVMs will never work. If you put coils into the feeding vessel, you may have done an immediate cure, but that's BS, because the AVM is still present. And so now new vessels will form and sprout into the AVM and will therefore cause like the AVM to recur. And maybe this is the reason why when you are doing a pre-surgical embolization prior to gamma knife, you should wait for at least 6 months after your pre-surgical embolization to do the gamma knife, because otherwise you may have just ligated the AVM. The gamma knife or the LINAC that delineates where the AVM needs to be treated is no longer, or not taking the segment out that you have only ligated, that is just not visualized, but it's biological still there. And then it only can work on the area that it's seeing. And so this is why patients, and this is what we've demonstrated in Toronto, who are pre-radio surgery embolized, they have a higher likelihood for developing recurrences, likely due to this mechanism here. Okay, future treatments. Last but one application. We talked about the KRAS pathway, we talked about HHT. Now the KRAS pathway it is a completely different pathway as compared to the VEGF-ALK1 pathway. In familial AVMs, i.e. in HHT AVMs, you can see that we'll need to inhibit the VEGF pathway with sirolimus or with avastin. However, in the sporadic AVMs, we have the KRAS pathway. And this KRAS pathway has a couple of subsequent steps, the BRAF and the MEK, where we can use MEK inhibitors. Now, MEK inhibitors, so here was, of course, the picture that I showed you for the HHT, but here are the MEK inhibitors. mitogen activated protein kinase inhibitors, or trametinib. And this has been demonstrated to work in peripheral AVMs. You can see how over time the MEK inhibitor indeed decreased the size of the AVM. But this opens now to you the immediate question: how can we identify whether a patient has indeed a somatic KRAS mutation that can be treated with a MEK inhibitor? We can't do a biopsy of the AVM, that will obviously lead to bleeding. And this is how or why we devised liquid biopsies. A liquid biopsy means that we are going into the vein as close as possible to the nidus and take blood from within this vein. And then we are doing mRNA sequencing to identify whether within the blood that is going through the AVM, that is naturally taking some endothelial cells with us, whether there is indeed a KRAS mutation present. And this was the case in this patient here who had an untreatable high cervical spine metameric syndrome, and he did venous sampling. The patient did indeed have a KRAS mutation. He treated the patient, and it got, at least it stabilized. Now we are now approximately, we've done, I think by now 12 to 15 cases. We're trying to publish our first series, and it's not as good as we had hoped to be very frank with you, because 3 patients had to stop the trametinib because it has severe side effects. In some patients we still demonstrated that there was growth and hemorrhage, and there were few patients that stabilized. None of the patients regressed their AVM. So lots of open questions, but at least is something where we may want to work towards. My big question is, can AVMs actually, once they have developed, even regress? Are MEK inhibitors the only ones? And pediatrics, what are the side effects, in particular in the growing body, where you actually need your KRAS pathway for your blood vessels to sprout and to grow? So lots of open questions here still, but I think an interesting potential that we may want to think about in the future. And the last one that I just added like recently is understanding these concepts of vasculogenesis and angiogenesis allows for so much more. Who of you is treating chronic subdural hematomas? I would believe the majority nowadays, after all of these positive New England Journal of Medicine studies. But why is it actually working? And is there a difference whether you're using coils versus particles versus liquids? Well, when we are thinking about the pathophysiology of chronic subdural hematomas, then it's of importance to realize that inflammation and angiogenesis are of importance here. Because what is happening in a chronic subdural hematoma is visualized here. We have here the meninges. They are normal. These are the vessels that you penetrate in with your onyx, with your true film, MBCA, etc. But this is not where the hemorrhages occur. The hemorrhages occur from the inner membrane. And the inner membrane is being is going through a process of angiogenesis, and these inner membranes are actually being the size of the vessels are 50 micrometers. So none of your particles will go there. Your particles will only go to here. They will not penetrate here. Your onyx will not go all the way to where actually the bleeding is. And this means that even with a ligation, you're doing nothing else but a ligation embolization, which is good, which works. But you're going not to the bleeding point. And this tells you, and this is of course now a completely different lecture on MMA embolization, that theoretically coils will work as well as liquid embolics, because you're doing the same thing with your coil, i.e. just a temporary ligation of your artery. But there are different nuances with this that we can, which I'm happy to discuss. That we now also have to do bilateral embolization, etc. But it's just for you to understand that With none of our liquid embolics do we actually reach our target, understanding the concept of angiogenesis and where it actually occurs. It occurs where we have the inflammation. And this is in the inner membranes. Then we can understand how dural arteriovenous fistulas work. Because in dural arteriovenous fistulas, we will have to have, this is known from animal experience, the combination of venous outflow obstruction together with the release of VEGF to develop the abnormal shunts. Venous congestion alone is not sufficient. VEGF alone is not sufficient. You need both for dural arteriovenous fistula to develop. Or it can help you to even understand certain types of aneurysms that we are discussing about. And these are those so-called partially thrombosed giant aneurysms where we know that the disease process is actually an angiogenic disease process within the vessel wall, where we have the sprouting and the formation of neovessels within the wall due to local hypoxemia. And these neovessels are VEGF dependent, therefore are leaky, and therefore are bleeding more often. And therefore the bleeding in these so-called partially thrombosed aneurysms is always beyond the lumen, which means that no matter what you put into the aneurysm will continue to grow. And this is this intracranial arterial aneurysmal vasculopathies where we need to target the outer vessel wall. Or look at AVMs. In AVMs, we have now identified that if you have like local thrombus formation, then you will have enhancement within the wall. So in this case here, there's thrombus right here, in this outpouching. This is where the enhancement is, and this is where the edema is. Which means that this point here is weak. And why do we have this? Well, if you normally have a wall that is not thrombosed, it will get its oxygen from within the vessel. If you now have thrombus, then the oxygen can no longer go and diffuse into the vessel, which means that your vessel will become hypoxemic, will become inflamed, and will therefore become more prone to rupture. This is what we've described recently here. So, in other words, and coming to the conclusion, trying to understand this concept of vasculogenesis and angiogenesis will move you hopefully away from thinking that you are nothing but a brain surgeon or brain plumber, i.e. where you just need to fix a couple of pipes in the brain, but where we are actually treating like very complex biological systems that need treatments focused on the cause of the disease rather than the symptom. And at the same time, it allows you that our field is constantly evolving, and that we, in the future, presumably can think about other things than the relatively crude methods that we are using now. And with this, I would like to thank you very much for your attention.